Good morning, everyone. My name is Ahmed Salahuddin. I'm a co-chair for the pre-course today for ACP Washington chapter. I am fortunate to have to get to share co-chair positions with Dr. Shiv Bhandari. So we're both internal medicine docs. I work at Providence Regional Medical Center in Everett. Dr. Bhandari works at the University of Washington. At the risk of sounding like an airline pilot at the end of a long flight, you could have spent your CME dollars just about anywhere, but we're so pleased that you invested in us, and it'll certainly be worth your while. We have some great content and some excellent speakers for you guys today, high yield topics. And before we dive into it, we have a couple of slides to get through. Number one is going to be disclosures for planning committee and faculty. And importantly, this is a safe learning environment, and our anti-harassment policy is available here for you. Importantly, if you see or observe anything that could be inappropriate or constitute harassment, we do have some phone numbers and emails for you to notify. Additional disclosures for the content validation committee is present there. And we do have CME available for this talk. So we'll go through these slides at the end as well. And importantly, licensure requirements are state specific. So that is on the ACP website. So with that, I'm going to close out my, I'm going to stop sharing. And Dr. McCooley, if you want to get your screen share up for your slides. And while you're doing that, I would be very pleased to introduce our first speaker, Dr. Caroline McCooley. So she is going to be covering content that is very anxiety-provoking for your general doc, the sort of stuff that keeps me up at night, and that is basically an inflamed patient not otherwise specified. Specifically, this talk is a rheumatologist's perspective of fever of unknown origin. Dr. Caroline McCooley went to medical school at OHSU, where she completed her IM residency thereafter at the Providence Portland Medical Center. She hopped back over the river to complete rheumatology fellowship at OHSU. She subsequently worked in a private practice in Bend, Oregon, before returning to the Providence community, where she now primarily works as a clinician at the Providence Portland Arthritis Center. She additionally directs the rheumatology curriculum and clinical experiences for its internal medicine residents, and did such a great job that she was honored to receive the Subspecialist Teacher of the Year award, as voted by the residents this past summer. So beyond all the excellent work she does as a rheumatologist and an educator, you can find her adventuring on trails, rivers, and mountains with her husband and 2 young children. Dr. McCooley, take it away.
Thank you. Thanks for the introduction. And I am excited to kick off this meeting with a topic that I think is relevant for every clinician and every subspecialist, and especially in the hospitalist world as well. So with that being said, we will dive on in here. This is my disclosure. So the objectives start with, first of all, defining what is a fever of unknown origin and making sure we're all on the same page as we dive deeper into the topic. Then I will review an evidence-based approach to evaluating the FUO. And then the bulk of the presentation today will be going through cases, patients that I have seen mostly in the hospital setting with an FUO, and ultimately these are, I'm going to break it to you, these are all rheumatologic diagnoses, but I like to learn by cases, and I figured that would be a fun way to do some teaching for you as well. And then I'll close with some thoughts about some global thoughts, and then final, just everything is clear as mud comments as well. So I think most of us could say, oh yeah, FUO, I know it when I see it. We should probably be a bit more specific. And the definition has actually evolved over time. Early 1900s, the FUO was described as a fever over 2 weeks. About 50 years later, they were more specific with a specific temperature, 38.3 Celsius. They added another week, so it's 3 weeks of no diagnosis despite a week of inpatient investigations. And FUO is sometimes evaluated in the outpatient setting, and so this has also been commented as well. Ultimately, there is no consensus, but some core features should be highlighted, and that is of course, okay, no identified cause of the fever. A reasonable number of investigations has been completed, and the fever has persisted long enough that self-limited fevers have been ruled out. We all know that sometimes people are sick, we don't really know why, and then they get better. That happens with the FUO as well. I really liked this modern definition from the New England Journal of Medicine review in 22, which really incorporated the above features, saying an unexplained fever despite high quality diagnostic workup after a reasonable amount of time has passed to rule out self-limiting fevers. So with that definition in mind, I want to highlight that also the causes of the FUO, excuse me, have evolved over time as well. The overall perception is that autoimmune and autoinflammatory causes are the predominant causes of FUOs, but that's actually not true. Infections remain the leading cause of FUO. This is more highly associated in lower income regions, but also true throughout the world. The causes vary by country, vary by type of hospital. So your tertiary hospital is going to see a different demographic, often different patient population compared to a more rural hospital. And then the most humbling part of this investigation is that over half remain undiagnosed. And this is thought to be higher in more likely in higher income regions, probably because there's overrepresentation of challenging cases and higher income regions have more diagnostic tools to make the infection and malignancy diagnoses. Today, I will just be talking about the classic FUO. As you can see listed here, there are multiple other types of FUO which change the differential diagnosis with these high-risk populations, those in the ICU, immune deficiency, organ transplant, etc. So now focusing into the autoimmune and autoinflammatory disorders that cause FUO, there it is thought to be about 22 to 32% of FUO cases are categorized as one of these. Oftentimes we use autoinflammatory and autoimmune interchangeably, but these are actually different disease pathologies. Autoinflammatory includes disorders of innate immunity, as opposed to autoimmune disorders, which are due to adaptive immunity. In reality, most of the diseases that we see will have a mix of the above, and I've listed here the commonly known polymyalgia rheumatica, adult onset Still's disease. These are mix of both pathways. Within rheumatology, we always have to be okay with a degree of uncertainty, and that's because many of the diagnoses are clinical, and we base this on pattern recognition and objective data where we can certainly have that to support our diagnosis. But we do rely on criteria to diagnose much of the time without a gold standard test. So when you're seeing a patient in the inpatient setting or outpatient, there are no specific clues that would indicate, this is a rheumatologic cause I should be investigating. However, it is thought that the FUO is related to an autoimmune or autoinflammatory disorder more commonly in older patients over 65. The older we get, the more wonky our immune system gets and can turn against us. Patients with an inflammatory arthritis component and cutaneous component also have a higher likelihood of having a rheumatologic diagnosis at the end. Lymphadenopathy, and then the longer fever duration. And part of the longer fever duration is that oftentimes the infection and malignancy has been ruled out. So a very basic framework is that, first of all, we need to rule out infection. We know this in part because infections are the most likely cause of an FUO. Then consider malignancy and doing an appropriate screening or proactive investigation for malignancy is indicated. And it's only at that point, once infection and malignancy have been ruled out, that we consider rheumatologic diagnoses. And first of all, we think about the more common rheumatologic diagnoses, even with uncommon presentations. And then after that, we're looking for zebras. And that's the kind of fun, interesting cases that we see on the inpatient side, which are the less common diagnoses. So I really liked this detailed proposed diagnostic algorithm that this same article from the New England Journal of Medicine had, with starting with your minimal initial evaluation. This is what we learn in medical school. We take a very thorough history, including medications, travel, any exposures, and then a really thorough physical exam. I think the art of the physical exam is declining at times. And this is one especially where doing a musculoskeletal exam, looking for synovitis, for effusions, a full skin exam, looking for lymphadenopathy, all of these are highly relevant to a diagnosis. Thereafter, we need to confirm a fever, of course, and if the patient is stable and not neutropenic, then withholding antibiotics is indicated in order to facilitate a more clear evaluation. And that is the caveat, is the patient has to be clinically stable and not neutropenic. Then the need for hospitalization is determined. So I think I'm speaking to hospitalists right now. This is where you will be involved as well. And then we do our minimal next evaluation. Most of these folks in the emergency room are going to be getting CBC, CMP, blood cultures, HIV, and then generally pan scanning with CT, chest, abdomen, pelvis. And then if patients have localizing symptoms, a CT scan elsewhere, such as a cervical spine and an echocardiogram. Also, one should consider discontinuing any new potentially offending medications. Thereafter, a more advanced evaluation is indicated. At this point, the epidemiology, exposures, and imaging can all help guide the next evaluation. So if someone has recently traveled to India, the tuberculosis is higher on the differential, for example. And then it's only at this point that the rheumatologic diagnoses should be considered, and then an appropriate investigation started, which we'll dive into later. And a biopsy should be considered as well for any a, for any area that seems to be inflamed. So a rash, temporal artery, if a patient is having signs or symptoms of giant cell arteritis, lymph nodes, masses, tissue is the issue is one of my favorite sayings. So at this point, you've either made a diagnosis, great, treat them accordingly. If you have a high pretest probability of a diagnosis, high suspicion, clinical suspicion, then an empiric course of doxycycline or antifungal therapy or tuberculosis therapy could be initiated. However, if you have not made a diagnosis, this is where the next step is, we reevaluate the clinical status, reevaluate the history, consider a factitious fever. I think with the hospital systems now with turnover of hospice, often you all are doing this as you're taking on a new patient without a clear diagnosis. Then performing new testing based on that reevaluation. The FDG PET CT scan is an emerging very helpful tool that should be done if not already. And I'll explore that in the next slide as well. And then if the additional tests are still unrevealing, considering a metagenomic testing to assess for infection. At this point, one could consider empiric anti-inflammatory therapy if not contraindicated, even if there's not a definite diagnosis. So this is gosh, should we try some prednisone and see what happens? And then, which doesn't always feel great, but sometimes is the reality. And then last of all, the least satisfying part of this algorithm is that there is the consideration that at this time in medicine, we may not be able to diagnose about half of patients with an FUO, and telling the patient that. The FDG PET CT scan is, we most commonly were familiar with PET scans in evaluating malignancy and for metastases, but is an emerging tool that we use in an FUO evaluation. This is where the radioactive substance, the FDG, is injected into the patient's bloodstream, and then areas of high glucose uptake and inflammation will absorb the FDG, and then that will light up on the scan. And then the CT scan shows detailed pictures of the body structures. Sensitivity is fairly high, 86 to 98%. Specificity not quite as high, but ultimately it is thought that the diagnostic yield is about 50%, which is significantly greater than the conventional CT scan. The performance is better in patients with an infection or malignancy. But I think pictures are fun. So I showed some PET CT images of a patient with a large vessel vasculitis. So giant cell arteritis is the most common. And you can just see here the large vessels are lighting up the aorta, the subclavians, femoral arteries. All of those are inflamed in this diagnosis. And um, this FDG PET CT scan made that diagnosis. Uh, because of the fairly good performance, a negative FDG PET CT scan does predict a high likelihood of spontaneous remission of the fever. So a negative scan is also helpful. And then briefly, this is far outside of my expertise, but the next generation sequencing, which was mentioned in the more advanced part of the diagnostic algorithm, is this unbiased sequencing of all genetic material in a specimen. So taking blood, looking for all the genomes, the bacteria, the fungal, and is a highly sensitive way to pick up infections that have not been diagnosed. But it does need more research. So we at Providence Portland have this tool. I don't know all of the facilities that have this though. So before we dive into the fun part of the cases, I have a few words of warning. First of all, diagnostic clues may be misleading. Patients have all sorts of different symptoms and sometimes have different findings on a physical exam, which may seem unusual, but actually not clinically relevant to the diagnosis. So there's always that caveat in the back of our minds. Many FUO syndromes are due to uncommon manifestations of more common conditions. And then finally, before ordering a test, we always need to consider the pretest probability of a condition, as there are false negative, or excuse me, false positive tests, and then also knowing that, for example, though people with infections, they produce antibodies. So you can often get a whole panel of positive autoimmune tests, and those would be impossible to interpret. Okay, now we are going to have a whirlwind tour of cases these are my patients. Um, our first patient is a 78-year-old male who's a retired fireman, a history of remote prostate cancer, hypertension, who presented in the outpatient world with 6 weeks of low-grade fevers. He described whole body pain and stiffness, and he actually had started getting his estate ready. He thought he was dying. He lost about 22 pounds. Pertinent negatives include denying headaches, vision changes, jaw pain, chest pain, shortness of breath. He was up to date on his malignancy screening. He lives in Newberg, Oregon, which is a wine country. Um, on exam, you can see his vitals here. He didn't appear toxic, but was tired. He of note needed help standing from a chair and climbing up onto the exam table, and then really had limited range of motion of the shoulders and hips due to pain. His data is listed here, which you can see signs of inflammation on his CBC. Chem panel is fairly unremarkable. Inflammatory markers, ESR and CRP, are highly elevated. And an astute clinician thought, oh, could this be polymyalgia rheumatica in this elderly gentleman with a shoulder and hip stiffness and pain and elevated inflammatory markers? And so provided an empiric low dose prednisone course, and the patient came back and said, oh my gosh, you are a miracle worker. I feel amazing. I'm back to normal. I don't think I'm dying anymore. So, our first autoimmune FUO today that I'm describing is polymyalgia rheumatica, PMR, and it's thought this is about 7% of autoimmune FUO cases. And close to 20% of patients with PMR will have a fever. The the term polymyalgia is a misnomer. There is no muscle involvement in this diagnosis. Even though patients will present and very often will rub the tops of their arms and the tops of their legs and say, it's just my muscles, I feel so stiff and achy. If you were to get an MRI of a shoulder or a hip, this shows inflammatory arthritis with synovitis, bursitis, and enthesitis, where the tendon is inserting into the bone. PMR is a clinical diagnosis. This is where folks show, God, they present and they say, I was fine yesterday, 1 week ago, but yesterday I woke up and I had to have help getting out of bed. I couldn't stand up from the toilet because everything is just so painful and so stiff. The distribution of these symptoms are in this image here, with that, again, the kind of neck, shoulder, hip area, and the buttock area as well. Everyone who has polymyalgia rheumatica is over the age of 50. So if you have a 20-year-old presenting with these symptoms, it is not PMR. Everyone has elevated inflammatory markers. And then part of the definition, part of the diagnosis is that 100% response to low dose steroids. So generally, that's no more than 20 milligrams of prednisone. If you give 20 milligrams of prednisone to this person and they come back a week later and they say, well, I don't know, maybe I was a little bit better, it's not PMR. Prednisone is magical for this diagnosis. A couple of things to note is that PMR is associated with rheumatoid arthritis, and about 5% of PMR patients will evolve to have rheumatoid arthritis. And then actually about 20% will develop giant cell arteritis. And the GCA can occur anytime, both soon after PMR diagnosis and years into the disease course. Additionally, this is a systemic disease, and so most patients lose a degree of weight. They can have fevers, as we've mentioned, and then fatigue, which of course is nonspecific, but generally folks feel poorly overall. All right, our second case is a 63-year-old female coming to the emergency room with 2 weeks of fevers, fairly high up to 103. She's lost some weight, and also describes episodes of diplopia. She notes that she's had some headaches, which feel different from her normal tension headaches, and some right arm pain, especially when she's using her arm. She says she's overall stiff and achy. Her outpatient provider sent her to an ophthalmologist because of the diplopia, and they noted a fairly unremarkable exam. On evaluation in the emergency room, she had a fever, a little tachycardic. Notably, her blood pressures in her upper extremities are different, with much lower blood pressure in the right upper extremity. Overall, she's appearing tired and non-toxic. Again, needs help getting onto that exam table. She, of note, has some tenderness along her temples, along the temporal arteries, and has, in a very thorough physical exam, has a diminished right brachial pulse compared to the left side. Her data is listed here with, again, inflammatory signs on her CBC, highly elevated inflammatory markers. She has a positive ANA. I highlight this because we often see a positive ANA, especially in older people, and it's not always clinically relevant. Because there was significant concern for giant cell arteritis, she underwent a temporal artery biopsy, which demonstrated both focal and segmental transmural inflammation with the multinucleated giant cells. This makes, with the clinical setting with this biopsy, makes a diagnosis of biopsy-proven giant cell arteritis, which is the most common large vessel vasculitis. Here are just a couple of images. First, on the far left is an ophthalmologic exam, which demonstrates flame-shaped hemorrhages and optic disc edema, which is fairly specific for giant cell arteritis. However, as our patient demonstrates, often not evident earlier on in the disease course. And so a negative ophthalmologic exam does not rule out GCA diagnosis. And then again, tissue is the issue. Here's the example of a biopsy of a normal temporal artery with the control. And this is a normal artery. And then you can see to the far right is a artery with giant cells in the lumina here. And we see significant narrowing of that blood vessel, which then causes a downstream ischemia, causing all of this clinical symptoms of giant cell arteritis. So GCA is about 11% of autoimmune FUO cases, and about 25 to 50% of patients of GCA will have a fever. This, again, is the most common large vessel vasculitis. And the diagnosis starts with a clinical suspicion, clinical concern, and then we do have objective data that helps to further define the diagnosis. Your most classic presentation is going to be an abrupt onset temporal headache. Vision changes are common, but not everyone has these. In medical school, we learn about emerosis fugax, this curtain coming down over the vision, which is actually fairly uncommon. Much more commonly, we see folks with diplopia or blurred vision, and this can be more of a stuttering presentation as well. The most the most specific clinical manifestation of GCA is actually jaw claudication. So this is where folks will find jaw pain or jaw fatigue with use. So, oh yeah, I've stopped chewing bread because my jaw hurts, or I've stopped chewing gum because my jaw hurts. And that's because with any type of vasculitis, there's inflammation of the blood vessel wall causing narrowing of the blood vessel, and then that leads to downstream ischemia. So the master muscle is affected by and here we can see this artery here. And so if you're essentially an MI in the muscle here, and so with use have that the symptoms of claudication. Just like PMR, everyone with GCA is over the age of 50. These folks have a vasculitis, which is very inflammatory. So always inflammatory markers are highly elevated. Um, they're, the older we get, the normal range of inflammatory markers increases. So there is a calculator online actually where you can put in your patient's age and then determine if the ESR is high or if this is actually within normal range for their age. This is a diagnosis, again, associated with polymyalgia. About half of patients with GCA will have PMR symptoms. In the United States, right now, the temporal artery biopsy is the gold standard diagnosis. However, there are false negatives, and this is probably in large part to a sampling error. We know this is not this is often not a confluent change in the blood vessel, and so we can have sampling error. There are also discrepancies between pathologists reading these biopsies. So in patients with high clinical concern for GCA, but a negative biopsy, we still end up usually treating the patients as having GCA. There's an emerging tool being used more often, and actually in Europe is the mainstay of diagnosis, is the temporal artery ultrasound, which shows a classic sign. This has significant reader or user and reader variability, and we need a radiologist who knows how to read these ultrasounds. Um, and then also note the ultrasounds are highly sensitive to steroids. So this, if a patient's had even 1 or 2 doses of prednisone, the ultrasound is not helpful. These folks have to have not seen any glucocorticoids to have a helpful ultrasound. And now also more recently, CT angiogram to look for asymptomatic large vessel involvement throughout the rest of the body is standard of care. This is because they're quite a high proportion of patients with the GCA will have extracranial involvement. And this long term matters because any area that a blood vessel has been inflamed, that blood vessel wall is weak, and even once the inflammation is down, and they are at high risk for aneurysms. And so changes how we or primary care will monitor for aneurysm development through the rest of their lives. All right, we're going to move into a different demographic here with a 21-year-old female who comes to the emergency room after 9 days of fevers up to 102. She describes a sore throat and headache, abdominal cramping. She tells the emergency room provider that she was seen in the urgent care twice over the past week. She had negative COVID and flu testing. She was tachycardic and febrile in the urgent care. She had a persistent fever the next time she went and had a little bit more broad workup, infectious workup as noted here. At that time, the ESR was normal, but CRP highly elevated. Procalcitonin is a lab used often around here, screening for bacterial infections. This is a fairly low number. And then she did have elevation in her AST. Her PCP thought, well, maybe she has a UTI, so gave her some amoxicillin. But the day prior to presentation to the emergency room, she became achy all over. Her throat was more sore. She developed a rash that would move around her body. And then the final straw was that her fingers became very swollen and painful, and she had trouble using her hands. So at this point, she comes to the emergency room. On exam, she's febrile, tachycardic. Her baseline blood pressure, though, she appears sick. She's miserable. She's got several tender cervical lymph nodes. She's tachycardic with a small murmur noted, some crackles in her lungs. Abdomen, she didn't guard, but was just diffusely tender. On skin exam, she has a diffuse coalescing erythematous macular papular rash. And she notes that this moves around even within a day. And then on a musculoskeletal exam, she's got polyarticular synovitis and she's got PIP, MCP involvement, as you can see in this image here, wrists, elbows. She's got warm effusions in her knees, ankle, and MTPs. Labs are notable for mild anemia. She's mildly thrombocytopenic, and then LFTs are fairly elevated. Initial infection labs are fairly unremarkable. She did have an elevated troponin when she went to the emergency room. And then some additional data include highly elevated inflammatory markers. Of significance, she has a negative ANA, and then highly elevated ferritin, LDH, and triglycerides. Because she was describing very sore throat, she had a focused CT scan of her neck, which did not demonstrate major abnormalities, abscesses, or tonsillitis. She was pan-scanned, which again didn't show any significant abnormalities. And due to the elevated troponin, had a cardiac MRI, which did not show any myocarditis and just trace regurgitation. So this patient, ultimately we diagnosed with adult onset Still's disease. And this diagnosis was made after an extensive infectious work ruling out as well. About 22% of autoimmune FUO cases are due to adult onset Still's disease. This is typically in the younger demographic, usually in the young adult, definitely below age 50. And there's a slight female predominance, but can affect men. Part of the definition of this diagnosis includes fever. So 100% of patients will have fairly high fevers, but it is a clinical diagnosis based on the Yamaguchi criteria. Um, so just to quickly review, the major criteria include at least 1 week of high fevers. Inflammatory arthralgias and arthritis is one of the major criteria. And just to remind you, arthralgias is when folks have joint pain, but we don't see anything, whereas in arthritis, we would see objective synovitis. The evanescent salmon pink maculopapular rash is also part of the major criteria. These are some major buzzwords for your internal medicine boards as well. And evanescent, meaning it moves around. And then finally, most folks will have a leukocytosis. Minor criteria include sore throat, lymphadenopathy, liver dysfunction, and then also a negative ANA and rheumatoid factor. Not part of the definition, but I would say pretty much across the board, patients have highly elevated ferritin, typically greater than 5,000, often close to 10,000, and then ESR and CRP are also elevated. These patients can get very sick very quickly. And so most with active disease are going to be in the inpatient setting, sometimes in the ICU. And one of the major fears is an evolution into macrophage activation syndrome, MAS. And this is characterized by fevers, elevated ferritin, cytopenias, and then elevated triglycerides is one of the signs. I don't know why, but it is. Low fibrinogen, and then these folks can get pulmonary edema, AKI, just end organ damage, and this is a life-threatening condition. Okay, now we're going to move on to, I say humble pie because we're all going to be humbled by this case. We're This is a 74-year-old Vietnamese male with thalassemia and hypertension presenting to the emergency room. He's had 3 weeks of fevers this episode, some nausea and vomiting. Over the past year, he has been hospitalized multiple times with FUO being the discharge diagnosis, with additional features of of specific organ inflammation, including uveitis. He's had colitis, which caused a small bowel obstruction, periorbital edema, retropharyngeal edema, ear swelling. He's had various cytopenias. He's lost 30 pounds over the past year without meaning to. By the time he got to see gastroenterology in the outpatient setting, the colitis had normalized and he had a normal colonoscopy, so that was not a helpful part of the investigation. And this is this list here, this happened over about a year, so I'm definitely creative license to kind of shorten this all into a smaller time period. But he was seen by hematology and oncology on the outpatient setting as well, due to anemia, the weight loss, and lymphadenopathy. He had some non-specific lymphadenopathy on a pan scan, and then ultimately was recommended to have a bone marrow biopsy looking for underlying hematologic malignancy. Before that happened, he saw an ophthalmologist and was diagnosed with uveitis based on their exam. And ID the whole time said, nope, this is not an infection. Contact hemonc and contact rheumatology. So this patient, when I saw him on exam, was febrile, slightly tachycardic, but appears tired and uncomfortable. He had some tender swollen parotid gland and periorbital edema as demonstrated here. He most notably then also had a erythematous patches on his trunk and extremities, which he notes that was a new rash for him, and no signs of an inflammatory arthritis on his musculoskeletal exam. Data here demonstrates mild leukopenia, anemia, even elevated creatinine with a sort of active urinary sediment here, highly elevated inflammatory markers. Ferritin is elevated, demonstrating inflammation, not as high as our patient with Still's disease, though he had elevated IgG4, an SPEP that showed some abnormalities but was inconclusive. He had a kidney biopsy due to the active urinary sediment and elevated creatinine. This demonstrated patchy interstitial inflammation and some global glomerular sclerosis and interstitial fibrosis. He underwent a bone marrow biopsy, which demonstrated hypercellular changes with myeloid predominant trilineage, hematopoiesis, mild myeloid megakaryocytic dysplasia, no significant blasts. And ultimately, with this patient entering into the zebra differential diagnoses, we checked a UBA1 genetic mutation, which I don't know if this is meaningful to you right now, but let me tell you, this mutation with the right clinical setting, as our patient did, makes a diagnosis of Vexus syndrome. This is vacuoles E1 enzyme X-linked autoinflammatory and somatic disease syndrome. It is It was first described in 2020 in the New England Journal of Medicine by a team at NIH, and is because it's only being described in the last 5 years. There's unknown the percentage of FUO autoimmune causes, but it is thought to be that is underrepresented. The incidence of this of Vexus is actually about 1 in 5,000 elderly men and 1 in 20,000 women. So unclear how many FUO autoimmune cases, but the incidence is fairly common in relatively. Um, most patients will present with a recurrent fever. As our patient, he had about 6 hospitalizations with discharges with primary diagnosis of FUO. More than half this will be the presenting symptom. So this is an adult onset inflammatory disease due to a UBA1 genetic mutation. The diagnosis is made first clinically, has to be the right setting. Um, with multi-system inflammation, the immune system has gone awry, turned against you, and attacks you. And this can really attack anything: skin, cartilage, lungs, heart, eye. Cytopenias, and especially macrocytic anemia, are very common. The bone marrow biopsy is part of the diagnosis with demonstration of vacuoles and myeloid and erythroid precursor cells. With this being such a new diagnosis, generally these biopsies are sent to tertiary centers. Our biopsy was sent to OHSU, where in addition to the genetic mutation, and the OHSU team helped to define, clarify the diagnosis for us, confirm the diagnosis. So this should not be the first diagnosis on your differential, but is one that if the patient doesn't fit into a box, and a lot of other diagnoses has been ruled out, and especially in middle-aged to older men with signs of multi-organ inflammation, the Vexus syndrome is probably under-recognized. So I think just having it on the radar and knowing about it is important. This here is just an image of all of the inflammation that can occur from head to toe. With really, you can see every organ can be involved and inflamed. Um, and because cartilage is a fairly large component of the inflammation, it is thought that patients with prior diagnoses of relapsing polychondritis actually had Vexus. So this patient here has a acutely inflamed ear where the cartilage is inflamed, and saddle nose deformity where he's had prior multiple episodes of inflammation of the cartilage in his nose here, with now thought of actually Vexus and not relapsing polychondritis. The cutaneous manifestations are broad. As you can see here, there's the chondritis component, periorbital edema. They can have a neutrophilic dermatosis, which would be a biopsy diagnosis, leukocytoclastic vasculitis, can have a cutaneous medium vessel vasculitis and urticaria. So really a broad range of skin manifestations. Our next patient is a 28-year-old African-American female who's pregnant, and she presents to the emergency room with fevers, shortness of breath, chest pain. She's feeling lightheaded. She's had daily fevers for the past couple of weeks. She notes that she feels short of breath most of the time. She's has to rest after walking across a room, and she'd attributed many of her symptoms to pregnancy, but due to progressive symptoms and now some pleuritic and positional chest pain and leg swelling. She's presenting to the emergency room. She also notes that she's had a rash on her legs, which is not itchy, but is new. Her exam's notable for mild tachycardia. She has a fever. She appears tired and uncomfortable, anxious. She's got some non-tender adenopathy on exam. She has an oral ulcer on her soft palate, which she was unaware of and is in the demonstrated in the upper right corner here. She's tachycardic with a small murmur, and then she had 2+ pitting edema in her legs. She has some diminished breath sounds in the lower parts of her lungs without any wheezing. She's pregnant, and then on her skin, especially in the lower extremities, some erythematous patches are noted. Again, as demonstrated in this picture. On exam, she has synovitis of many joints, including PIPs, MCPs, wrists, elbows. Her knees and ankles are also inflamed. Her data is here. The admitting hospitalist had a high concern for systemic lupus given her clinical presentation, and she has a high titer ANA, 1 to 1280, high titer dsDNA, anti-Smith. Also, an SSA antibody is positive. She has hypocomplementemia, and then she does have some evidence of inflammation in her urinalysis. Her basic lab workup is noted for pancytopenia. On echocardiogram, she has a moderate-sized pericardial effusion without tamponade, and then also moderate-sized pleural effusions. Due to the lymphadenopathy and concern for lymphoma, initially she had a lymph node biopsy, which demonstrated follicular hyperplasia with some necrosis. So this patient encapsulates a pretty classic presentation of systemic lupus. As we all know, lupus can almost do anything, but she highlighted some of the um, manifestations that we should all know about. First is that about 11% of patients with an autoimmune FUO will end up being diagnosed with lupus. 40% or so of patients with lupus report a fever. So not everyone gets a fever. The diagnosis is uh, based on multiple puzzle pieces. So first of all, we have to have clinical suspicion. So our patient had pericarditis. She had pleuritis with pleural effusions, pancytopenia, inflammatory arthritis, cutaneous manifestations. She really hit most of the disease manifestations. So the serologies are a part of diagnosis, but we do not check the serologies without clinical suspicion. That is because the ANA test is highly sensitive. So everyone with lupus will have an ANA and usually high titers. However, there are folks with other diseases and also asymptomatic, healthy population who has a positive ANA and no diagnosis of lupus. Um, dsDNA is more specific for lupus and especially lupus nephritis, and the dsDNA does track with disease activity. So if you're seeing a patient in the hospital with known lupus and fevers, and there's a question of, is this the lupus? Checking the dsDNA and then C3 and C4 are helpful because these track with disease activity. Oftentimes the dsDNA will be elevated, all of the time in active lupus, complements C3 and C4 are low. And then the anti-Smith antibody is the most specific antibody for lupus and also portends a um, more severe disease potential. Cytopenias are most common, usually active disease. Again, folks are having leukopenia, often anemia, thrombocytopenia. Serositis means pericarditis, pleuritis, and then peritonitis as well can occur. Nephritis is about present in about half of folks with definite lupus diagnosis. And then I've mentioned the cutaneous and inflammatory arthritis manifestations as well. There are much more or uncommon manifestations, including CNS, lupus. So this is not an exhaustive list, but these are definitely the most common. Okay, our next patient is a 68-year-old Hispanic male farm worker with hypertension who's presenting to the emergency room with a primary complaint of not being able to breathe. He notes that about 6 weeks ago, he had a dry cough. He was treated with azithromycin by urgent care. Didn't feel any better thereafter. He's now feeling more short of breath, having a hard time working. And for about 5 of these weeks has had fevers up to 102, drenching night sweats, and lost about 25 pounds. More recently, he's developed an erythematous rash on his legs, and his legs have become swollen as well. And ultimately, he was transferred to Providence Portland Medical Center for critical care support, given his hypoxemic respiratory failure. On exam, he is tachycardic, a little bit low-grade fever. He appears tired, sitting in a dark room. His eyes are injected, at both of them, and he avoids light. And also the sclera are erythematous. His gums are swollen, as demonstrated in this picture. And he's got a small murmur on exam. He has scattered crackles. On his legs, he has erythematous palpable purpura, and then no musculoskeletal findings. His basic lab workup is notable for renal insufficiency, renal failure. He has signs of inflammation on his CBC. Urinalysis demonstrates active urinary sediment, again, with elevated RBCs, white blood cells, and granular casts. He had a CT scan, which demonstrates some cavitary lesions and hazy opacities in both of his lung fields. Due to the renal failure, he had a kidney biopsy, which demonstrates focal and segmental necrotizing and crescentic GN and no complex deposition. He has a low titer positive ANA, and then notably the positive c-ANCA and PR3 serologies. So this patient, ultimately, we diagnosed with granulomatosis with polyangiitis, GPA, which is one of the more common small vessel vasculitides. About 7% of autoimmune FUO cases ultimately are diagnosed with GPA. And then over half of patients with GPA will have a fever. So I think, first of all, it's when I wanted to know, when do we consider a small vessel vasculitis? A vasculitis is often a sort of a black box for a lot of physicians. First of all, anytime there is multi-system inflammation and ischemia, a small vessel or a vasculitis should be on the differential. If you think about the pathophysiology, all these little tiny blood vessels in our bodies, they become inflamed, the vessel wall becomes inflamed, get narrowing of the vessel itself, which then leads to decreased blood flow, and therefore any end organ can be ischemic. Also weird ischemia. So the 20-year-old coming in with an MI, that's weird. So it should be considered a small vessel vasculitis. Pulmonary renal syndrome is also where we would have this on the differential. Certainly much more commonly, you're going to be treating folks with pneumonia and a pre-renal azotemia. But if folks are not getting better, how you would expect with your interventions, then considering small vessel vasculitis, such as GPA, would be indicated. Um, and then, as we're talking about today, that systemic illness and FUO in general, um, as you're going kind of down your diagnostic algorithm, the vasculitis should be on the differential there as well. Diagnosis starts with evidence of a small vessel vasculitis. So most commonly is going to be in that either pulmonary renal syndrome or the multi-system ischemia and inflammation. Tissue is the issue. We love a biopsy to prove a diagnosis, which demonstrates vasculitis, blood vessel infiltration into the vessel wall. However, it's not always safe or to obtain a biopsy. So sometimes we have to clinically treat. And however, most often folks will have a positive ANCA serology. So this is a really helpful part of the puzzle when we're trying to make a diagnosis. Um, there is an entity called ANCA negative GPA. Usually these folks have more limited disease from kind of neck and higher. Um, I have never seen folks with multi-organ involvement, lung involvement, kidney involvement with negative ANCA serologies. Um, but yeah, that's just part part of the just muddy waters that we work in. Okay, we've got two more cases here. This next one is a 39-year-old female. She's 7 months postpartum, coming to the PCP in the outpatient world with several months of polyarticular inflammatory arthritis. She thought this was maybe just part of postpartum period, but notes that because of pain and swelling in the hands, she's even having trouble lifting her baby up. Sleep is disrupted by pain and the baby, of course. She's had daily low-grade fever. She has lost about 30 pounds. She's overall just feeling kind of short of breath and tired. And then her left eye is actually irritated and sensitive to light and red. On exam, she does not have a fever today, and overall stable clinically. She's mildly tearful. Um, the most notable exam finding is that she's got polyarticular synovitis in almost every joint, every peripheral joint as described here. So with the concern for a patient with chronic polyarticular symmetric inflammatory arthritis, there's a high possibility of rheumatoid arthritis, which would be high on our differential diagnosis in this setting. Her labs here demonstrate high titer positive rheumatoid factor and anti-CCP, which make a diagnosis of seropositive rheumatoid arthritis in this clinical context. She does have a positive ANA, but no other features of systemic lupus, so is not clinically relevant and certainly would not make a diagnosis of lupus. Rheumatoid arthritis, is a fairly uncommon cause of an autoimmune FUO. However, rheumatoid arthritis is the most common rheumatologic diagnosis in general. So I did want to include it in today's presentation. And about 6% of patients with RA will have a fever. And fevers can occur any time from early on in the diagnostic evaluation to periods of active disease. This is a clinical diagnosis, and again, the polyarticular symmetric inflammatory arthritis, everyone has this, and by definition, greater than 6 weeks of symptoms. This is a often proliferative and destructive type of arthritis in which the synovium becomes inflamed and then proliferates and can destroy the joints. Everyone knows about the joint involvement. However, RA is a systemic disease. And so folks can have fevers and weight loss, but also can have organ involvement. The eye is fairly common with episcleritis and scleritis. So our patient had episcleritis. Lung involvement can be a manifestation. This includes ILD, pulmonary nodules, and effusions, pleural effusions. These would be a diagnosis of exclusion. You need to biopsy and tap it to make sure we're not missing an infection or a malignancy, of course. And then about 80% of people have positive serologies. Not everyone. I was at a conference recently in which the presenter said that seronegative rheumatoid arthritis is actually an opportunity to reconsider a diagnosis. But for our purposes, we'll say most of the time positive serologies, with the anti-CCP being much more specific. All right, our final.
Dr. McCooley, it looks like we're at time.
Oh,
It may make sense to, and I hate to do it, skip this last case.
okay.
I did want to be able to at least take one question. And viewers, the presentation slide deck will be available for you to review. So anyone with questions, I'll give it a moment. And you can certainly submit the questions, and I could route them to Dr. McCooley to answer. Uh, and then what I will do is, if no questions, I have one burning question. Um, in a patient, all paths lead to I'm going to call and beg for help from the rheumatologist. And I appreciate your algorithm of, steroids. I feel like steroids is a damned if you do, damned if you don't. As a rheumatologist, would you prefer that if we're kind of getting to that point, just wait for the consult so we don't muddy the waters with the steroids, or is it kind of a wash, or is it all right for us to just pull the trigger?
I mean, I think if you have access to a inpatient rheumatologic consultation, unless if the patient is clinically stable, we would prefer you hold off on the steroids, just so that we can have that at least one objective evaluation. And then if there are any labs that we want that may be affected by the steroids. Um, if you are working in a vacuum and don't have access to rheumatology and you're kind of into this algorithm and don't know what to do, then yeah, it's a very reasonable intervention.
Thank you. And one quick question, in Vexus, is Vexus the same as relapsing polychondritis?
No, no, Vexus is much more broadly inflammatory and is related to this specific genetic mutation. Is actually much more potentially life-threatening compared to relapsing polychondritis.
Amazing. Thank you so much, Dr. McCooley, for enlightening and empowering us in these challenging cases.
Well, and
Um,
I apologize. I went too long. I think I practiced faster in my head.
oh, you
Uh,
did great. So what I'll ask you to do is stop your screen share, and we'll get up the next speaker. Thank you so much.
okay. Thank you. Bye.